Hello, welcome to the Center for Connected Health Policies Telehealth and Medicaid Policy Webinar Series, Fall Edition. Today's topic will be on telehealth and patients with disabilities. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. A few disclaimers and friendly reminders before we begin our webinar. Please note that any information provided in today's webinar is not to be considered legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with your organization's legal counsel if you have a specific legal question or you want a formal legal opinion. Also know that neither CCHP nor any of our speakers have any relevant financial interest, arrangement, or affiliation with any organization or product that may happen to be mentioned during today's webinar. Please also note that our speakers, due to their state positions, cannot recommend technology platforms for you. Today's webinar is being recorded and slides will be presented here that will be made available after the webinar. Please check CCHP's website a couple of days after this webinar. Additionally, closed captioning is available, and as you can see, we also have sign language interpreters as well. If you need to increase the screen size for your sign language interpreter screen, you can enlarge it by dragging it on the corners to enlarge the visual. We also ask that people please refrain from making political statements or advertising commercial products during the webinar. A bit of background about CCHP. CCHP was established in 2009 as a program underneath the Public Health Institute. We were established as a California telehealth policy organization, but an opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through a grant from HRSA. CCHP applied for that, received the grant, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal level on telehealth or connected health projects. We act as well as an administrator for the National Consortium of Telehealth Resource Centers, which is made up of the 14 telehealth resource centers who are underneath the same program as CCHP. We also act as the convener for the California Telehealth Policy Coalition, which is a coalition of over 100 statewide and national groups who are interested in advancing telehealth policy in the state of California. National Consortium of Telehealth Resource Centers, as I mentioned, is made up of the 14 telehealth resource centers underneath the same program as CCHP through HRSA. There are 12 regional resource centers that cover specific states and 2 national centers, one on policy, which is CCHP, and one on technology. We work collaboratively together in order to make maximum use of our resources and also to cut down on duplication of efforts. This telehealth Medicaid policy webinar series is funded through a grant from HRSA provided to CCHP from COVID funding. Our next webinar will be on October 8th when we'll be talking about permanent policies from COVID policies that were temporary that were made permanent in Medicaid programs. For today's topic, we will be focusing on telehealth and how it can be used to treat patients with disabilities. As you will know, these are not representatives for Medicaid programs, so we actually expand the topic slightly and the reach of our speakers here slightly from what we have been usually doing. Instead of focusing in on Medicaid, we're looking at what states may be doing for people with disabilities and how they've been crafting their telehealth policies or trying to assist those patients with a disability. Just a few key policy things and reminders that I want to remind folks of before we go into our panels and our speakers. Important federal laws to keep in mind when talking about a patient with a disability. Keep in mind that these requirements in federal law and state law do not change simply because you are using telehealth to deliver services. Important federal laws to keep in mind are the American Disability Act, Section 504 of the Rehabilitation Act, and Section 1557 of the Affordable Care Act. It's also important to know that what you provide, when you provide services to patients, you must do it through effective communication channels. So simply, for example, having closed caption during a telehealth encounter may not be an effective means of communication with your patient. You have to find the means in which you would be able to communicate effectively with that particular patient. Additionally, please note that some states may have more stringent or other requirements beyond what the federal law requires you to do. So with those few things to keep in mind, I am going to turn it over to our first speaker, who is Ivanora or Ivy Alexander from Kentucky. She is with the Office with Children with Special Healthcare Needs. Ivy has served as Executive Director for the Office of Children with Special Healthcare Needs in Kentucky. Prior to joining OCSHCN, she worked in the field of rehabilitation engineering as a service provider and later a manager, where she designed devices and systems for adults and children with various disabilities, including spinal cord injuries, neurological disorders, brain injuries, and musculoskeletal injuries. She initially joined OCSHCN as the Health Information and Technology Branch Manager and HIPAA Privacy Officer, where she supervised the development of and reporting from a custom electronic medical record. Later, she became the Assistant Director of Support Services. In that role, Ivy was responsible for building partnerships, expanding outreach, and implementing gap-filling services for children and youth with special healthcare needs across Kentucky. As Executive Director, she is responsible for policymaking and the administration of programs related to specialty medical and therapeutic services for children with special healthcare needs. This includes overseeing statewide newborn hearing screening, audiology services, early intervention services, coordination for one region of Kentucky, family support, and the provision of specialty pediatric service delivery and care coordination. OCSHCN is a Title V agency within the Kentucky Cabinet for Health and Family Services and has a 97-year history of providing care to children across Kentucky who have special healthcare needs through direct service and collaborative partnerships. So I'm happy to turn it over now to Ivy.
All right. Thank you, May. Next slide, please. So today I'd like to speak with you all today. I'm going to give you an overview of the Office for Children with Special Healthcare Needs. And you heard a little bit about that in the introduction, actually, but you'll hear a little more repeated. And then tell you about our telehealth program that we currently have in place and how it shifted in 2020, the barriers that we came upon, and then the solutions to those barriers. So next slide. So the Office for Children with Special Healthcare Needs was started back in 1924. The Kentucky General Assembly established our organization, and we are a Title V agency. So we're part of the Maternal and Child Health Bureau's program. Our focus is on children and youth with special healthcare needs here in Kentucky. Next slide, please. Our mission, of course, is to enhance the quality of life for children here in Kentucky and their families. We do a lot of collaboration. So we collaborate with other organizations to ensure services are provided. We have parents that advocate and parents that connect with each other. We do education and leadership, and then we do have direct service as well. So that's what we'll focus in on today when talking about telehealth. Next slide, please. Our vision, just to give you an idea who we are, we want to be a leader, a visible leader in supporting the highest quality of life for Kentucky's children. And again, that's going to be through collaboration. And one of our main focuses is to really provide or ensure that services are available in an individual's community, right where they are. So our agency typically does gap filling services. We have some direct care, but we try to fill only the gaps and to ensure that services are available. Next slide. So we are located across the state. You'll see here a visual of the state of Kentucky, and it's very colorful. Each of those colors represent our 11 districts. Within those districts, we have 12 different offices. So we have nurses, nurse care coordinators in 10 of those locations. Along with the nurse care coordinators, we have social workers, audiologists, and OT, PT, and therapists, basically speech therapists, occupational therapists, and physical therapists. Most of those are on contract. And then we also have early intervention service, and then one of our offices is strictly audiology. So we try to cover the state, again, just filling the gaps where needed. Next slide, please. So I've said children with special health care needs, maybe 5 or 6 times already. And I just want to clarify that definition. So on your screen, you see the definition of a child with a special health care need that is used by the Maternal and Child Health Bureau. So basically, we're talking about a child from birth to 21 who needs more care than normally would be needed for either chronic physical, developmental, behavioral, or emotional condition. So that is the population that we serve. And here in the state of Kentucky, we have about over 200,000 children that meet the definition. Next slide. Thank you. The Office for Children with Special Health Care Needs, this is a list of our current services that we do provide. A lot of these were mentioned in the introduction, but early hearing detection and intervention, it's collaboration with our birthing hospitals across the state. We do early intervention service coordination, which we call First Steps here in Kentucky, and that prepares babies from birth to 3 to get them ready for school. We're really known for our specialty medical clinics, which are located across the state. And again, we contract with providers from the 2 main universities here in Kentucky, as well as other providers and communities to come to our locations to provide clinical care. We have care coordination services, which is huge for us here in Kentucky, just to ensure that families have an individual that works with them to ensure that they're getting the appropriate care and the appropriate appointments, if they need transportation or if they need assistance with transportation or food, if they have overnight stays for the hospital, if their child's going to be having surgery, we can help out and coordinate with all those type of things. Of course, we have audiology and hearing aid services, OTPT speech therapy. We have a medically complex foster care support team, which actually has transferred to one of our sister agencies, but they had a huge part in the telehealth transition. And also our family to family program, which is huge to ensure that parents have the support they need. And again, various partnerships and collaborations across the state. Next slide, please. So I just want to focus in, I mentioned the specialty pediatric clinics, and the items listed here are the diagnoses that we treat in our clinics. So there are 8 different diagnostic types, diagnosis types, and these occur across the state various times and in various locations. And again, we have our providers that go to our locations. Next slide. So let's start talking about the telehealth program. So the history of telehealth here in Kentucky, or at least for the Office for Children with Special Health Care Needs, we initiated our program back in 2013. So we've been doing telehealth for a long time. We started it off with our neurology clinics, and then a few years later added our autism clinics. So the purpose, though, or the focus at that time, again, our providers are in an urban area. Again, we contract with physicians, usually from Louisville or Lexington. And then they might drive out in parts of the state. They may drive 2 hours out to one of our locations to see patients and then drive back. So the initial thought process for the telehealth program back in 2013 was when basically that provider or that family could see the provider more often through telehealth without that provider having to drive that distance. So it was more, I want to say it's almost provider focused because their drive was limited. It did increase access for the families, but it also assisted with the providers. Always the telehealth visits at the beginning were just the nurse care coordinator, and they were with the family at the remote location out in, like say, Hazard, Kentucky. And then the provider was in the urban area, and then the connection was made that way. Next slide, please. So the modification, we modified it in several ways. The first thing that we did in 2020, in March of 2020, because of the concerns with the virus that was going on, we expanded basically to everyone. So originally, it was only individuals out in the rural areas that were enrolled in the telehealth or could, enroll in a telehealth clinic. But March 2020, around April 2020, it was any and everybody that needed services could be treated through telehealth. For that reason, we expanded to the medically complex foster care program. The home visits, that was one of the first things we did, is stop the home visits on site and use virtual visits. We added additional clinics beyond neurology and autism to telehealth. Our service coordinators for the First Steps program did teleintervention as well, and speech, OT, and PT did teleintervention. Next slide, please. So due to that huge change, because we all had to shift really quickly at that time just to make sure care continued, but we took a snapshot from the year prior, so March of 2019 to February of 2020, we had 836 telehealth visits. So then we looked from March 2020 to February 2021, that following year, and those visits jumped up to 3,571. Our population overall is about 8,000 children in our program. Next slide, please. The other modification, and this was the main one, of course, telehealth typically is from one location to another location, so 2 locations involved. And of course, we added a third location so the family could be at home. The provider would be at the physician would be at their location, and then our care coordinator would be at a third location. So between the 3 individuals that created that telehealth visit. Next slide, please. So we identified some barriers initially. So the first was just when everything was changing and we started moving into more video-based services, there was a limited understanding of that. We found that not everybody has the technology to do telehealth. And if they do have the technology, maybe they don't have internet services. And then also we, as an agency, weren't representing, all of our specialties weren't represented in telehealth at that time. It was just the 2, neurology and autism. So I'll go through each of these barriers in a little more detail. Next slide, please. Next slide. So we'll talk about the limited understanding of the video-based. Essentially, we understood that there was just a gap there of understanding. So Family Voices put together a series. They actually had a grant, and we applied for a grant through the CARES Act. And their series was regarding telehealth. And our parent consultants here, we applied for the grant, received the grant to provide the training here in Kentucky for families. So it was actually 4 different modules that they created and that we were able to provide to families here in Kentucky. Are you connected? Do you have a device? Can you see your provider? And your first telemedicine visit. So those were the 4 topics. So those were provided by video-based instruction, and anyone that was interested across the state, they did not have to be a patient at our facility or at our offices. It was available for anyone across the state interested. The series was given in both, we had English sessions, and then we also had sessions in Spanish as well. So that was the first way we increased the understanding. Next slide, please. And then we did something that was more personalized for the families. We had a pre-visit, or we have a pre-visit mailing, and then also a pre-visit call for the first time that they do telehealth. So our pre-visit mailing, basically we send them a document, either emailed or mailed, snail mail, a telehealth instruction sheet. And the items that are listed here are the items that are covered in that document. So understanding what telehealth is, and then preparing for the meeting, what to do the day of the meeting, what they do if they need to cancel, and then how can they use telehealth or video-based visits in other ways. So somebody, an Ocean staff person or that person's care coordinator reaches out to the family to make sure that their device is set up, that anything that they might need to download is ready. They kind of do a trial run beforehand. So that provided a more comfort level for the families that telehealth was new to. Next slide, please. So the other barrier was the technology itself. Okay, so the issue of not having the technology or not having internet services or not having, even if they did have service, maybe they didn't have enough data or they wanted to say limited data, a limited data plan. So next slide. What we did is we applied for another grant, another CARES Act grant, and this one was through the Association of Maternal and Child Health Programs, AMCHIP. And we created a lending library here in Kentucky, specifically for children and youth with special health care needs for their medical appointments. So as long as they're birth to 21 with child with a special health care need, they can receive a device from our lending library. So it's a tablet that we have, a protective case and stand, and then the internet connection within that tablet. It's sent out to the family. They're able to utilize that system, the device, for their appointments, and then it's returned to us. Next slide, please. So then the barrier of not all specialties are represented in telehealth. Now that's on the agency. This is specific to the Office for Children with Special Health Care Needs. So I showed you our list of clinical specialties, our medical clinics. And I mentioned that autism and neurology have been doing telehealth for years. We still do the on-site care as well as the telehealth. So it's a combination at this point. But we, again, autism and neurology are still going. The other areas, occasionally we have done telehealth as needed. So for those in that first column, we're developing 2 new items. Cardiology is somewhat already developed. We've got the technology and the equipment for that. But for the cardiology, it's just not, that would be used as a last resort. It's more ideal to be on site for those cardiology appointments. So we're structured and we're set and we're ready for that, but it has not been utilized. And then one thing that we're working on is networking, getting our systems networked so that we can do remote programming for hearing aids and cochlear implants. And that will be the audiology version of our telehealth program. The only thing that we have not been able to move or shift to telehealth at this point is our ophthalmology and our eye clinics. So those will be structured just as face-to-face at this point. Next slide, please. So those were the major barriers initially, but of course we want to continue to understand what barriers are out there. And so we provide surveys to our patients and our families and to our providers. So the next few slides will show some results. So 60% of our parents and our families, our parents basically thought that the difference between a on-site visit with the doctor versus a telehealth visit was excellent. So 60%, that's okay. 35% said it was good. So 60%, and you'll see in a later slide some of the reasons for that. Next slide, please. One of our other questions was based on their experience with the telehealth through the Office for Children, would they be willing or interested in doing other types of telehealth? And 67% of the respondents said definitely, 21% probably. And there was one that said definitely not. Okay. Next slide, please. So there were, these were the top survey responses on what went well with the telehealth visit. And this survey, just so that you know, right after the visits started, when we initially opened up the program or expanded the program, we reached out immediately after the telehealth visit to ask these questions of the family. So the number one reason was reduced risk of exposure to contagious illnesses as compared to an in-person visit. That was the number one response. The fact that they received instructions before the visit was done well, and the reduced stress as comparing to having to travel, deal with parking, to get daycare, transportation, that was the reduced stress was one of the top answers. And then being able to provide or to include other professionals in the visit went really well. So when we're on site, and typically we would have the physician in the room, the care coordinator in the room. If an interpreter is needed, they would be in the room. We might have a nutritionist come in, plus the child, the family. So in an exam room, and of course, in March, April of last year, and really now, we're still limiting the number of individuals that can be in the room together. And so from a video standpoint, video-based conference, we can start to increase those numbers again and have more individuals involved in that visit. And then, of course, reduced missed time from school and work was also went well. Next slide, please. And then what did not go well, and this is reflective in that 60% of those folks that I mentioned earlier, the number one reason was my child and I weren't able to interact as well with the provider as compared to an in-person visit. So in speaking with some of the parents, of course, it depends on the type of visit it is and what the need is, what their concerns are as to whether they would choose to do telehealth or do in person. The number two reason is technical issues, lost connections during the visit. And then number three is having trouble hearing and or seeing the provider during the visits. So, initially we thought we did, work with the families to make sure they were all set up, but had to go back and make sure the providers as well were ready as well. Next slide, please. And so we also interviewed or surveyed the providers. And again, these are contracted providers, so they have their own practices and they come to us just specifically for our clinics. It might be once a month, it might be 2 or 3 times a month. But they had high satisfaction because of that initial coaching that we did with the families. They spent less time on technical issues and more time with the patient as compared to their own visits, their own telehealth visits that they do at their locations. And then the big one was just being able to see that patient in their own environment. You see a little bit more and understand that individual in their environment that helps with enhanced care and recommendations. For example, somebody mentioned recommending a Hoyer lift. When they saw the space, it's something that they would not have recommended. So just being able to see them in their environment, and then also the children, some of the children being in their at home, there is a different interaction with the child in that environment as well. So next slide. So in summary, we expanded our telehealth program very quickly. We all changed a lot last year, in last summer, to be able to keep individuals safe. So we expanded our options in 2020. We really relied on the CARES Act grants that we received we were able to provide technology for the families, internet access for the families, and training for the families. We wanted, and we are continuing to monitor our patients. We survey them for even the regular visits, but especially the telehealth visits. And we're looking at how we can really structure telehealth in the future. Some things work with telehealth and others don't. So technology does have its limitations. So we want to make sure that the patient is being seen on site when necessary versus by telehealth. Next slide. Sorry. Thank you for your attention. And I'll turn it over to May, actually.
All right. Thank you, Ivy, for that great presentation. Quick question for you. Mm-hmm. You had said that you greatly expanded telehealth when the pandemic hit. Were all your telehealth providers sort of like the usual telehealth providers that you typically had before the pandemic who you knew were very experienced? Or did you also take on a lot of new contractors?
So our providers we had the team, our largest team is the neurology providers, okay, mm-hmm. The neurology contractors. So they were already experienced with that telehealth process. Mm-hmm. And then the other providers that we have, even though they were not contracted with us, they were still doing telehealth in their own areas. Mm-hmm. Primarily the University of Kentucky and University of Louisville is who we contract with those university hospitals. So it was, I'd say maybe half of the providers that we used were used to telehealth.
Okay, yeah, that I was wondering if that influenced some of like the experience that the patients had, that maybe they weren't as experienced with telehealth because there were so many providers pivoting towards that in the early days of the pandemic, that it may have it went for like maybe not the smoothest interaction with families.
Yes.
So. All right, so we've got a lot of questions for you. Just a reminder, and I think I neglected to mention this in the beginning, if you have a question for our speakers, please put it in the Q&A function. We're trying to reserve the chat function just for technology issues that you may have with Zoom. So that really helps us like organize it. And I'll actually turn more to the Q&A first. So to get your question answered quicker, it's best if you just put in the Q&A function. But we have one from Sherry Collins, who asked, service covered along with speech therapy, etc. What about language development, ASL? Do you cover that as well?
So through our early intervention, you mean through our early intervention program, so our ADDIE program, we do. And again, that's something that we contract out. We have a lot of collaborations. So we do that. Now, whether or not they're using telehealth, I would have to get that answer, but we do provide that service.
We have a question from Anonymous. I understand there is a current waiver that prohibits an initial in-person speech language pathology visit before utilizing telehealth is set to expire in January. This seems problematic for many telehealth providers, particularly those who work directly with schools. Do you have a sense of if that waiver will be made permanent or extended?
Yeah, I do not have a sense of what they're going to do with that waiver. We do keep up with what the emergency regulations that came into place because of the pandemic. And we have regulations here in Kentucky specifically to speech, OT, and PT and audiology telehealth services.
From Mary Vidmar, how did you get the tablets to the families and how did they return it specifically?
So our technology team spent a lot of time thinking about how to ship the technology to them. So they're actually mailed to the family, and in that box is another box to return. The postage is all paid, everything is paid for. So it's through the mail. We also, it depends on the location. So if the family is close to one of our offices, they can also just drop it off at the office, but it's structured to be mailed back and forth.
Mm-hmm. And to sort of limit that contact, because in those early days of COVID as well. And we'll take one more question before we go over to our next speaker, but know that Ivy will be back for full panelist Q&A at the end. This is from Dr. Paul Glassman. Are you using any form of telehealth to enhance dental care?
Not at this time. No, we are not. Most of our dental providers are through our cleft lip and palate clinic. And primarily that clinic is still on site, a majority of that clinic. So,
all right. Well, thank you, Ivy. As I said, Ivy will be back with us after our next speaker has gone. So I am going to share my screen again and introduce our next speaker. So just give me one moment here. All right. And our next speaker is Jan Withers, who is Director of the Division of Services for the Deaf and Hard of Hearing, North Carolina Department of Health and Human Services. Prior to joining division, Jan served as Director of Student Support Services at the North Carolina School for the Deaf in Morganton. She began her professional career as a mental health therapist for deaf and hard of hearing children. Jan is a founding member and has served on the board of directors for the National Association of State Agencies of the Deaf and Hard of Hearing. Jan Withers currently serves as the president of the board of directors for TDI, a national nonprofit that advocates for communication equity in information and communications technology. Jan received her master's degree in counseling from Gallaudet University and a bachelor's degree from Davidson College. So I will now turn it over to Jan.
Well, thank you so much, May, for that. I really appreciate it. It's an honor to be here and to be part of this webinar series. So I want to give you a little bit more information about myself and the agency that I manage. The North Carolina Division of Services for the Deaf and Hard of Hearing, or DSDHH, has 7 regional centers that cover all 100 counties of North Carolina. We serve deaf, hard of hearing, and deaf-blind people and their families. We also work with agencies, organizations, and businesses that provide services to those communities. We are also responsible for administering the contract to provide telecommunication relay services that allows deaf, hard of hearing, and deafblind people to make phone calls to people who do not have any kind of specialized equipment for receiving those calls. And that's specifically for the deaf, hard of hearing, and deafblind populations. We have about 75 full-time permanent staff, plus an additional 15 to 20 temporary staff that are responsible for providing direct services. And they primarily focus on advocacy for communication equity. And they do that in a variety of settings. It could be social services, in healthcare settings, working with law enforcement or the court systems, even within homes. So we provide training and consultation to different agencies and organizations and businesses across the state to try to ensure that their services and resources are accessible to the deaf, hard of hearing, and deafblind communities. And that is what I'm going to primarily focus on for the rest of our presentation. We are also part of the North Carolina Department of Health and Human Services, and our sister agencies include Medicaid, mental health services, public health, rural health, health services relations, state-operated facilities like psychiatric hospitals. And so we work very closely with all of those sister agencies as well. And I'm going to talk a little bit more about that as we go through our presentation. So if you go to the next slide, please. So our goals for this presentation today are that you would gain an awareness of and recognize the importance of communication equity in healthcare, that you would understand how to ensure that policies and procedures and guidelines translate to effective practices that result in communication equity. We also would like you to be able to access key resources that are designed to foster communication equity in telehealth, as well as in other healthcare encounters. And also that you will have access to and be able to contact subject matter experts in building your capacity to ensure communication equity, both in telehealth and in healthcare in general. So a lot of my emphasis here is going to be on that last point today. We'll go to the next slide, please. So I'm going to give you a little bit of demographic information about North Carolina. And I thought about looking up some national numbers, but I think that might be a little bit too abstract. I want you guys to think about the actual impact of what we're doing, because I think the impact is what matters. So in 2019, the total population of North Carolina was about 10.49 million. If you look at just the Black community in North Carolina, that was about 2.25 million. The Hispanic or Latino community was about 1.02 million. The population of deaf, hard of hearing, and deafblind in North Carolina was 1.2 million. And understand that all these other figures include birth onward, but our figures for people who are deaf, hard of hearing, and deafblind are actually only those who are 18 and older. So that number is an underestimation. So it's a pretty significant portion of our population. And we're expecting by the year 2030 that there'll be about a 33% increase in that population. So the people who have hearing loss will increase substantially. But in the same time period, the general population is only expected to increase by about 21%. So the obvious answer is that North Carolina is a popular retirement state, but also is a popular state for work moves. I believe in 2021, they estimated that there was about 10 till we have about 10.7 million people by the end of the year. So that's already a pretty significant increase, and it's only continuing to grow. Now, if you look at the breakdown of age groups of people who have hearing loss, you see here, that's probably not a surprise. We all know that as people age, the number of people with hearing loss typically increases. And there are some specific factors that may influence each state. So in North Carolina, we have a lot of veterans because North Carolina has 17 military bases that include over 700 and have over 700,000 veterans. Next slide, please. So speaking of veterans, hearing loss among veterans is the leading combat-related disability. They think about 60% of veterans returning from combat experience hearing loss and or tinnitus. That is higher than PTSD. That's a larger number than those who have lost limbs in combat. And if you read more about that, what becomes very interesting is that people often do not talk about hearing loss as a significant disability. And so I'm going to talk a little bit more about that as I go through this presentation as well. Now, other states have different unique populations, like New Mexico. There's a very large Native American population there. There's a large population of Spanish speakers in New Mexico. There are also a large population of older adults there. Now, when you look at just nationwide, hearing loss is the third most chronic and treatable health condition among older adults, second only to arthritis and hypertension. We also see significant comorbidities with hearing loss are diabetes, dementia, and falls. Now, this information typically is more related to people who acquire a hearing loss later in life. And maybe their 40s, 50s, and 60s. For people who are born with a hearing loss or have hearing loss very early in life, we don't see the same comorbidities necessarily. So those who lose their hearing later, I mean, of course, people who are born with hearing loss can experience those, but it's not seen as a significant comorbidity for people who have hearing loss early in life versus those who have hearing loss later. I also want to emphasize when I said it's the most third chronic and treatable condition, the reason for that problem is that you have to address the hearing loss first for people to be able to benefit from other interactions with a healthcare provider. So let's say they have their arthritis and hypertension that need to be managed. If they can't communicate with their provider, they can't manage those well, right? Next slide, please. Okay, so another thing about hearing loss is that it is a hidden disability and it's often overlooked. Typically, someone may just be misunderstood. And of course, we can't handle that all the time. There are professionals working in other fields. And there's a lot of people to work with. In our agency, we focus on communication equity. That's the thing that we have chosen to target. And that's a simple goal, but it is not easy to achieve. The actual application of that and the achieving of that goal is quite complex. So when you look at our populations, there's three broader categories. So deaf, meaning they typically are born deaf or they lose their hearing before acquiring spoken language and typically will use American Sign Language more often. The hard of hearing community most likely lost their hearing later in life, maybe their 40s, 50s, and up. They typically do not know American Sign Language. And some hard of hearing people also have a progressive hearing loss that worsens as they age. And then within the deaf-blind community, there is an incredible variety because you have a combined vision and hearing loss, and each of those varies based on individual, based on age of onset, based on the severity of those losses, and the type of vision and hearing loss that they have. So that community is incredibly diverse. Next slide, please. So given those three different populations, it makes sense that a one-size-fits-all approach is not going to work. from the categories that I just listed, deaf, hard of hearing, and deafblind, those are basic, broad categories, but within each, you could break that out into quite a lot of subgroups, and it becomes more and more complex as you look at that. You have a lot of different communication needs within each of those broad groups, and those different communication needs have different solutions. So for patients whose primary language is American Sign Language, English is typically a second language. And it's important to understand with that American Sign Language and English have very different grammatical structures. Something that's actually very interesting is that American Sign Language has more in common with spoken Chinese than it does with English, grammatically speaking. So also, there's a group of people who would benefit more from something called CART, or Communication Access Real-Time Translation. And that's a live captioning. But there is a lot of patients that wouldn't benefit from that. Maybe people who are deaf and for whom English is a second language. Also, people who have a hearing loss but don't have a hearing aid may benefit from that. Unfortunately, there are a lot of people that aren't familiar with or aren't able to afford some of the other tools that could be effective for them. So I'll talk a little bit more about some of those as well as we go through this. When you look at the deafblind community, of course, that adds a layer of complexity because you're dealing with the degree and type of both vision and hearing loss, and both of those need some sort of accommodation. Next slide, please. So again, when we talk about people who lose their hearing later in life as adults, there is typically a 7-year delay from onset until they begin to seek help or treatment for that hearing loss. And that impacts their ability to benefit from a variety of different services. It also impacts their benefit in healthcare services. Also, hearing aids are often outside of affordability for many people. Insurances don't typically pay for hearing aids, and they're very expensive. Among the veteran population, there's an even longer delay typically in seeking treatment for hearing loss. So think of it as a slow boil effect. As someone puts off something longer and longer, things become more difficult. And so what we actually notice in our agency is a lot of times the adult children of a person with hearing loss are calling us looking for help. Also, many people have poor self-advocacy skills, and that I want to actually talk about a little bit more. About 90% of adults who start losing their hearing could benefit from hearing aids, and only 16% actually use hearing aids. So if you think about how that translates into telehealth or even an in-person appointment with any kind of healthcare professional, it's a significant impact. All right, next slide, please. So just to summarize a couple of larger barriers that we see. One is that many deaf, hard of hearing, and deafblind people don't have the knowledge or resources they need to effectively advocate for themselves, particularly when it comes to communication access in different areas of their life, and that includes healthcare. The second larger barrier is that healthcare providers lack the knowledge and resources to make sure that their deaf, hard of hearing, and deafblind patients have access to those services that are on par with the general population's access. So I do want to mention that there are some incredible self-advocates out there, whether deaf, hard of hearing, or deafblind. But sometimes, even when someone is a great self-advocate, the system presents so many barriers that there's no way for them to break through that and get the access that they need. Next slide, please. Okay, so now I want to talk a little bit about the deaf, hard of hearing, and deafblind experience. So specifically, when you think of healthcare, there are a lot of incorrect assumptions made by healthcare providers, and that can come up when they're scheduling an appointment. So maybe the scheduler or the provider doesn't have any experience working with someone that has hearing loss. Or maybe they do and they don't realize that they have that experience. And so accessibility is not something that is typically considered. Sometimes people just assume that a person that has hearing loss is responsible for providing their own accommodation. So they'll frequently say, okay, well, make sure you bring your own interpreter. That's one we hear all the time. Another one is people saying, well, I'll have to wait to show up at my appointment and see if there are going to be accommodations provided. That's something we hear from people often that I want to talk about specifically, because a lot of deaf people request a live interpreter. And that's an interesting sort of cultural interpretation. So when a person who's hearing hears someone saying live interpreter, they may think what we have now. The interpreter we have is a live person, they're on screen. But when deaf people say live interpreter, they mean on-site interpreter. Another common thing that we hear is people saying, I'll have to explain and cite federal accessibility laws and convince the scheduler or provider that they're obligated to provide accommodations, and then guide them through the process of obtaining those accommodations. Right, next slide, please. So the result of that experience is that many of us experience hypervigilance, meaning we're always looking for, okay, are they going to provide an interpreter? Are they going to have captioning? Is it going to be set up right? Are they going to have done their homework? Do I have to check with them 3 or 4 times? Another result of that is advocacy exhaustion. Every time you have a new situation, it's okay, here I go again. I've got to advocate for myself again. And I had one person comment on this. It was actually a husband and wife, and requested an interpreter every time they were referred to a different department within one hospital. And that's not acceptable. They should not have to do that, right? And so as a result of this, many people also develop a distrust in the system. When they're always concerned, okay, was the interpreter even going to be there? That's what I requested. And a result of that is that a lot of times people avoid healthcare. Their health could deteriorate further, and they may not actually go to the doctor when they need to. Next slide, please. So the North Carolina Institute of Medicine and our agency, DSDHH, partnered back in 2019, and we set up a task force. And I think we met about 7 times with that task force. And the focus of the task force was how to address all of these complaints that we're hearing from the deaf, hard of hearing, and deafblind community. Complaints about not having communication access in healthcare. More than half the people there were representatives of different healthcare systems, which was a shock to me. And that's kind of the biggest thing that I've taken away from all of that, that one of the gaps between the deaf, hard of hearing, and deafblind community and healthcare system, that's where a lot of the gap is, because they would say, well, of course we provide interpreting. We have video remote interpreting. We can just wheel that right in and it's fine. But the problem is that what we hear from deaf, hard of hearing, and deafblind people is that VRI is ineffective. The technology freezes, or the picture quality is very poor, or it is set on a fixed stand that you can't adjust in any way. I think there have been many problems cited, and the healthcare systems will say, okay, we'll make sure you have an interpreter available. And when a person arrives, they're told, oh no, we can just write back and forth for this appointment. But it's important to understand that writing back and forth for a complex medical appointment is not acceptable. The Journal of Health Communication partnered with the University of North Carolina, that has a public health program, and with Gallaudet University to do a study. And that study found that many deaf and hard of hearing people expressed frustration with getting communication access services. So I suggest, I've got these 2 articles cited here. I really suggest that you take time to read those if you have a chance. Next slide, please. So the next 4 slides are going to show some data from a recent survey that we conducted and just did that this past summer. The sample size was about 261 people total, including deaf, hard of hearing, and deafblind respondents. So it was fairly small. But that group, because of the survey being online, we suspect is probably more likely to be tech savvy and more likely to have access to telehealth. They can use their own devices. We also found that people who had been more likely to experience VRI, which is something that's managed by the healthcare providers or doctor's office. So when deaf people were asked, they said they prefer to have an interpreter on the screen with the provider at the same time. So 78%. But only 26% said they didn't want that. Okay, and the next question that was asked was about captioning services. And we asked who prefers to have captioning, and only 28% said they preferred that. Only 5% of respondents received those services. Next slide, please. So this was looking at the different reasons that people expressed that they had a poor telehealth experience. And I'm not going to go into great detail about all of those. You'll see a little bit more about it on a future slide. But if you have a chance to just look quickly at those reasons that people listed below, but one in particular, that the provider didn't practice good communication strategies. And very often I find that right now, especially, providers are wearing masks during a telehealth appointment, and that can present a barrier. Or that's because they may be in the room with other staff or nurses or someone, and they have people moving around behind them. That also makes it potentially visually distracting or noisy so that a person can't hear. We'll go to the next slide, please. This is addressing some of the different technology barriers that people cited when accessing telehealth. And again, you can take a look at that yourselves. You already heard in Ivy's presentation a little bit about this. So go to the next slide, please. Now, we had some questions that were asking about the number of patients who used a patient portal to request things like an ASL interpreter, CART, or other accommodations. And this was not very good. A lot of telehealth providers are failing to ensure that their deaf, hard of hearing, and deafblind patients have a way to request accommodations for telehealth. Next slide, please. So when we ask if did the deaf, hard of hearing, and deafblind communities feel like they are fully included and engaged? And if they do, then we feel like that will result in a better just healthcare experience and a better health outcome. And I think there are a lot of research and data to support that. So that is how we get communication equity. Next slide, please. So May already mentioned some of these things as well. This is maybe just as an FYI. But I think it's important that you take the time to become familiar with these, and that leads me to my next slide. The first bullet here is a place where you can do a deep dive in learning more about the legal obligations for healthcare providers. And I believe there are also other resources there, like general telehealth questions and some different situations in which you can contact the Office of Minority Health And just as a reminder, when you look at hearing loss doesn't discriminate against for any particular racial or ethnic group. It's something that affects everyone. All right, next slide, please. So again, this is just a list of some further resources. If you were to look at that first link, that I strongly recommend as a starting place for providers. It gives an overview of different disabilities and sort of an introduction to those, and then also can lead to some further research. All right. Next slide, please. So how can you, as state agency representatives, whether that's with Medicaid or any other sort of area of health focus, what can you do? So what we have learned in particular through this last year in talking to our consumers who are deaf, hard of hearing, and deafblind, and talking with our sister agencies, we've realized that for us to effectively communicate and for there to be a communication equity, we have to address this at a system level from the top down. So that starts with contracts, policies, procedures, and guidelines. And we have already found that a lot of providers have a sort of we're developing sort of boilerplate language. And we see in people's contracts that they have this very vague language, but it doesn't actually lead to effective practices on the ground. So an example of that is that we were working with North Carolina Medicaid on the specific language, and there had been language for an enrollment broker. And they said, oh, well, we require the people who run the call centers, who answer the phone calls, that's who needs to make sure that people have a TTY phone number provided. And that was it. That's all they said. There was nothing else there. So we advise that a lot of people don't use TTYs anymore. If that's the only thing you're thinking about, I mean, I couldn't tell you when I even last saw a TTY, probably 5, 6, 7 years ago. Most deaf people like me aren't using TTYs anymore, but that's the language that is being put in a lot of these policies or contracts. So we need to make sure that they're adding language that reflects current technology, and also that reflects the ways that deaf, hard of hearing, and deafblind people are using that technology. So we provide training at various levels within state agencies to work on that. And our goal is to ensure that all health plans, and this is maybe something that's important for you, we want to ensure that all health plans, whether that's Medicaid or other healthcare providers, understand those best practices, that they are creating communication accessible environments and materials, and that they're providing correspondence that's accessible, but also that they have an appeal and complaint process when that doesn't happen. Also, these organizations need to budget communication access. They need to plan for providing those services, and they need to have a designated primary contact for setting those things up. So one situation we had is that we kind of intervened with a local dialysis clinic because they were providing VRI, and the staff there did not realize that the patient getting dialysis was deafblind. Now they could see well enough to walk and kind of what was happening around them, but they could not see well enough to understand the interpreter on the screen for VRI. And we eventually learned that that clinic was part of a national company that sets up clinics in different states. And their national headquarters was actually in another state. So I had a staff member who finally was able to get in contact with the right person that was the vice president of policy. And that person said, well, VRI is sufficient. That's what we provide. It works for everybody. And we had to explain to them why that was not the case. And as a result, we were able to get effective communication in place for this individual. And we explained to them, you need to make sure that whatever communication accommodation you're providing, it is effective for and matches the communication needs of each individual. And they were able to actually change their policy and approach from the top down. And that's why I say that this has to be a top-down solution to a large degree. Next slide, please. So at a provider level, whether that's a doctor or an office administrator, the people that are in charge there need to consider all of these different things as possible accommodations and make sure that any correspondence that they have matches the communication needs of the patient they're communicating with. That means ensuring any kind of application or forms or explanation are accessible. They need to also ensure that their staff are trained to handle phone calls that may be coming in through different methods. So maybe that's through a relay service, maybe that's through video phone, and learning how to communicate with those callers. So all of these things are something that those providers need to consider. If we go to the next slide. This is where I can talk to you guys as either state agencies and the ways that you can make the biggest impact. So what an agency like mine does is work in collaboration with other agencies like yours that could be Medicaid, public health, mental health, any of those agencies to ensure that your policies and procedures and guides have the capacity to meet the communication access needs of your patients. And so we are not a standalone agency. What we do is provide consultation and training. And we typically use the word technical assistance. But I think we also have come to like the term capacity building. So when we're working with any of you guys or other agencies in our state, what we want to do is build your capacity to meet the needs of your deaf, hard of hearing, and deafblind patients or clients. So when you find the appropriate partner that has the knowledge of those communities, like the National Association of State Agencies for the Deaf and Hard of Hearing, for instance, that's a place where you can find an agency like ours in your area. Not all states have an agency like ours. And in those states that don't, there are other agencies that you can find, or nonprofits, sometimes not state-based agencies that provide similar services. Like sometimes vocational rehab is a great place to get some of that information, or other agencies that specialize in providing mental health services to deaf and hard of hearing people. So even in the absence of a state agency for the deaf and hard of hearing, there are resources, and this, the National Association of State Agencies of the Deaf and Hard of Hearing, is a great place to start with that. Right. Next slide, please. So what can you do? First, I would definitely ask that you consider this a communication equity in healthcare issue. And understand that that is absolutely critical. You need to make sure that you have people at the table who are deaf, hard of hearing, and deafblind, because they are the experts in their communication. And that's how you're going to get to communication equity. And I've already explained, you contact sister agencies through that national association. Find ways to connect both on the ground in the field with agencies that work with deaf, hard of hearing, and deafblind people. So for example, some county departments of public health have maybe a field office that you can partner with. And yeah, you can work with a state level public health, And there may not be a field office in a particular area, but if there is, you can find out and partner with them. Also, including communication access in policies, procedures, and practices is very important. And remember, connecting with deaf, hard of hearing, and deafblind people is one of your best bets. So next slide, please. So what about other disabilities? Right, I haven't talked about a lot of those. I've not talked about those disability groups because my area of expertise is deaf, hard of hearing, and deafblind. However, you can follow some of the same principles and processes, find sister agencies that serve those populations. And a good place to start with that is vocational rehabilitation. I think about, let me see, so 22 states. No, there are 34 states and territories that have a single vocational rehabilitation agency that serves all disability groups. There are 22 that have a separate agency specifically for the blind. And every state has some sort of commission on intellectual and developmental disability. Also, every state has an assistive technology program. So those are some great places to start contacting to find subject matter experts on different disability groups. And that's what I have. So thank you very much for your time and attention.
Thank you, Jan, for that great presentation. We've got quite a few questions in our Q&A box. I will remind the folks that please put your questions for our speakers in the Q&A box, not in the chat box. So first off, Jan, I wanted to touch upon something that you mentioned in your presentation where you said that actually this may not necessarily be a telehealth issue and not having effective communications for person with a disability. It may be something that's carried over from just sort of like the protocols certain providers or institutions might have in place already, thinking that just sort of one size fits all for somebody with a disability, not realizing that there are each patient is different. They're going to have a different approach possibly with how they receive their care. So it's not necessarily a telehealth specific thing. It may just even be sort of like institutional protocol. And I also wanted to touch upon what really surprised me, because I read a lot of policies in different states, so I've seen it, the fact that a lot of policies reference probably out-of-date technology like TTY is also problematic, and like saying that because maybe it's not on the providers and it may be that they're just following the policy there, but the policy itself might be out of date with out-of-date technology referenced.
That is correct. Yes, we have noticed that. And it's very true. And that's why I strongly recommend that you have subject matter experts there at the table, at the top level, again, the top down. And it's important to also refer to resources like CMS that could help you with this as well. You can involve lawyers. But in my experience, there's a time when lawyers have a lack of sufficient understanding to ensure that the policy language will actually work on the ground. I can give you a good example of that, actually. Many times, an interpreter is called in, or CART. That is what's needed. And oftentimes when the patient needs two interpreters, one interpreter and one certified deaf interpreter, because the complexity of the language need of that patient that the provider may not understand. There may be other circumstances also where you have to be creative to meet the patient's needs that a lawyer may not think about or people at the top may not think about. Subject matter experts need to be at the table and work as partners. That's crucial.
Mm-hmm. That's why with CCHP, we like to have everybody who it impacts around the table just to make sure it works out for everyone. But your your comment about like having a certified medical interpreter there is especially relevant because, you know, if you're deaf, sign language, it is another language. It's like any type of foreign language. If you speak Chinese or Spanish, for example, I have to translate for my parents who speak Chinese. I don't know all the medical terms to translate that. So I will struggle with that. And that's why, you know, I insist on also having like a medical translator there as well too. Same thing with somebody who might be hard of hearing or deaf.
That is also correct. One thing I'd like to mention real quickly about telehealth in particular is an on-screen interpreter, ensuring that the telehealth platform that's being used includes enough screen space for an interpreter. One for the patient, one for the provider, one for the interpreter, and a place for captions as well on that same screen. So I would recommend that you go to the National Association of the Deaf. Their website has a lot of information about accessibility when it comes to technology and what requirements would meet the needs of most patients. But again, subject matter experts are the key just to make telehealth work for everyone.
And Jan, you're psychic, because that was actually one of the questions I was going to put to you from Sam Krause, who asked, Jan, how does the size of screen impact telehealth outcomes, smartphone versus tablet versus desktop? Because in the beginning of COVID, there were allowances to use smartphones, but you're absolutely right. It's so small where you need like maybe multiple screens to like have the interpreter, the provider, and the patient.
Correct. And like Ivy had also mentioned, there are other barriers to communication. The person may be deaf, but can't afford a device that's large enough or can't afford broadband services for that connection. They may be in a rural area that broadband is not even accessible to them. So there's a lot to consider in that. And there's also situations where they have an appointment in person that BRI could be inappropriate, but we think about the mask barrier in communication. So they need to have the interpreter or the captionist on the device to help with that communication in the office as well. So we need to think about that approach as well.
Mm-hmm. You also brought up a good point of somebody who may be deaf but speak a foreign language. So there's a question from Anonymous. How can we support our late deafened patients who is Spanish speaking only? We can't figure out how to communicate efficiently with them. They don't speak any sign language. They can read and speak Spanish, but there isn't someone who can scribe in Spanish for the patient at every visit.
That's a good question. I have not myself experienced that, but in Florida, they're have one of the biggest Spanish-speaking populations. Texas, California are other good examples, and they may have captionists or cart writers who are fluent in Spanish and can provide that translation from English to Spanish in the captioning form. So maybe contacting those areas. And in my field with the deaf, hard of hearing, and deafblind, the fact that you can find all of those and, you know, different racial and ethnic groups, you have to be creative. You have to think outside of the box. So again, the subject matter experts, asking them what resources they have is important.
And as our audience can see, we're also joined back again by Ivy Alexander. So these questions will just go to both of you right now because we do have a lot of questions that apply to both of you. Do you have any comparison on how telehealth appointment satisfaction compares with in-person? Meaning, was telehealth better or worse than in-person, as it seems in-person visit experience poor accommodations as well?
This is Jan. Wow. I think it depends. That's our famous answer. It depends. And thinking of that in rural areas, for example, where the sign language interpreters are not abundant, it takes a good broadband connection, a bigger monitor, a deaf person who's technically savvy. So if the medical conversation is not too complex, not in depth, not making a decision about a huge surgical procedure, for example, then telehealth could absolutely work in a rural area. But it may be easier to get an in-person or on-site interpreter. If the deaf person is clear that they benefit from those in-person interactions, we have to prepare for that. So it's important always to schedule these things in advance to see what's best for each person. It really depends what outcomes are better. Now, the National Association, NASDHH, can also help you reach out to these agencies that can help work with you on best outcomes to make these decisions for the patients or with the patients, depending upon their preferences. So the National Association of State Agencies for the Deaf and Hard of Hearing would be a great starting point for those.
Ivy, this question was directed to you, but Jan, you might have some insights as well. It says, thank you, Ivy, for sharing your telehealth experiences. We are in need of patient support to facilitate a smoother process for the patient and provider. Are there resources available to share your patient support materials that your staff use to guide the patients?
Sure, I could share that information. If you would like to send me an email, my email is, actually I can type it in the chat. It's ivy.alexander@ky.gov, and I can share those resources. I also mentioned some of the training that was created by Family Voices and their website. I'll put their website in the chat as well. They have good resources as well.
Do Kentucky or North Carolina have any statutory or regulatory barriers to telehealth, such as not allowing a patient's home to qualify as originating site for Medicaid coverage of telehealth visits? And this comes from Alicia Lane Outlaw.
For Kentucky Medicaid, the location of the patient location is actually the place of service, and that location can be their home, it can be school, a clinic setting, the workplace for Kentucky Medicaid.
We have a question from an anonymous attendee. What needs to happen to get healthcare providers to offer captioning for those who don't sign for their appointments? I know depending on insurance, sometimes interpreting services are covered, but not always. What about captioning?
This is Jan. I can comment on that. I can't speak for other states, of course, but CMS gives states the option to provide sign language interpreters as a standalone reimbursable service. North Carolina is one of those states that provides that. And it is a general rate for all Medicaid providers. They must provide the kind of accommodation that meets the patient's communication needs. That's key, meets the communication needs of the patient. So yes, CART would be covered.
Does Kentucky allow for telemedicine where the school is the originating site?
I want to verify that. I would have to verify that. But again, the location of the individual, the school is considered as one of those areas. So the place of service is where the individual is, and school is included in the regulation as a place.
You can also check on CCHP's website because we do link to each state's Medicaid policies as well. And I know we recently updated, because we heard from Donna, Ivy, we recently updated Kentucky's policies on there as well. So you can also check CCHP's website at cchpca.org. And our last question is from Sam Krause. Have you worked with the federal Lifeline program to get people a free smartphone at all?
So we used that or offered that as a resource. The information was sent out to our care coordinators and social workers to, inform families of that information. So we are aware of that.
All right, that is it for our questions, and we're also right about at time. So I just wanted to say thank you again to our fabulous speakers, Ivy Alexander and Jan Withers. I'm just going to share the screen again really quickly. So thank you again to our fabulous speakers for a great presentation. If you did not look at the chat box, there's a lot of compliments for you both in that chat box there, so you might want to check that out. Just to let you know, this webinar was being recorded. The recording and the PowerPoints will be made available a couple of days after this webinar, so check back on CCHP's website next week. You can also subscribe to CCHP's newsletter to stay abreast of any new webinars that we have planned, and also other telehealth policy developments throughout the country. Our next webinar will be next Friday on October 8th, and we'll be looking at COVID-19 policies that have been made permanent. We'll hear from Oregon, North Carolina again, and Arizona regarding what they have done. Please note that when this webinar ends, you will receive a link to an evaluation survey. We really ask that you fill that out. It'll only take a few minutes because it really helps us developing future programs and to know if this has been of any use to you. Once again, I really want to thank our speakers, Ivy Alexander and Jan Withers. Thank you also to our fabulous interpreters for the hard work that they did today, and our captioner. I also want to thank my staff at CCHP for helping pull all these webinars together. And lastly, thank you to our audience members and attendees for being here today with us. Everyone have a great day and stay safe.